Welcome. Today we'll be discussing hypogonadism, a condition where the body doesn't produce enough sex hormones. These hormones, primarily testosterone in men and estrogen in women, play critical roles in sexual development, reproduction, and overall health. We'll explore the causes, symptoms, diagnosis, and treatment of this condition, offering a comprehensive understanding of both primary and secondary forms. The causes of hypogonadism vary depending on whether it's primary or secondary. Primary hypogonadism originates from a problem within the gonads themselves, the testes in males or the ovaries in females. This could be due to genetic conditions like Klinefelter syndrome in males or Turner syndrome in females. Other causes include autoimmune diseases, infections like mumps orchidis which damages the testes, injuries or trauma to the gonads, or even exposure to radiation or chemotherapy. Secondary hypogonadism, on the other hand, stems from problems in the brain, specifically the hypothalamus or pituitary gland. These areas control hormone production. Causes can include pituitary tumors, Kallmann syndrome, a genetic disorder affecting the hypothalamus, inflammatory diseases like sarcoidosis or histiocytosis, head trauma, obesity, or the use of certain medications like opioids or anabolic steroids, which suppress the body's natural hormone production. The pathophysiology of hypogonadism depends on the type. In primary hypogonadism, the gonads fail to respond appropriately to stimulation from the pituitary gland. The pituitary is working fine, sending signals like follicle-stimulating hormone FSH and luteinizing hormone ALA to the gonads, but the gonads are unable to produce sufficient sex hormones. This leads to elevated levels of FSH and LH, as the pituitary tries harder to stimulate the unresponsive gonads. In secondary hypogonadism, the problem lies in the hypothalamus, or pituitary gland. The hypothalamus may not produce enough gonadotropin, releasing hormone again Rh, or the pituitary may not produce enough FSH and LH. Without these signals, the gonads are not stimulated to produce sex hormones, leading to low levels of both sex hormones and gonadotropins. Hypogonadism prevalence varies widely based on age, sex, and the specific population studied. It's more common in older men, with studies suggesting a prevalence ranging from 20% to 50% in men over 60. However, hypogonadism can occur at any age. Klinefelter syndrome, a cause of primary hypogonadism in males, affects approximately 500 to 1 in 1,000 newborn males. Kallmann syndrome, a cause of secondary hypogonadism, is rare, affecting approximately 1 in 10,000 males and 1 in 50,000 females. The rise in obesity and type 2 diabetes is thought to be contributing to an increase in hypogonadism cases globally, particularly in men. The signs and symptoms of hypogonadism depend on the age of onset and the severity of hormone deficiency. In males, symptoms may include decreased libido, erectile dysfunction, fatigue, loss of body hair, decreased muscle mass, increased body fat, gynecomastia, breast enlargement, infertility, and osteoporosis. In children and adolescents, delayed puberty, impaired growth, and small genitalia may be observed. In females, symptoms can include irregular or absent menstrual periods, infertility, decreased libido, hot flashes, vaginal dryness, and osteoporosis. Both sexes may experience mood changes, cognitive difficulties, and decreased energy levels. Diagnosing hypogonadism involves a combination of physical examination, medical history, and laboratory testing. A physical exam helps assess for signs like decreased muscle mass, gynecomastia, or abnormal genital development. Blood tests are crucial to measure hormone levels, including total and free testosterone in males, estrogen levels in females, and FSH and LH in both sexes. Low levels of sex hormones with elevated FSH and LH suggest primary hypogonadism. Low levels of sex hormones with normal or low FSH and LH suggest secondary hypogonadism. Other tests, such as semen analysis in men or pelvic ultrasound in women, may be performed to assess fertility or identify underlying structural abnormalities. If a pituitary problem is suspected, an MRI of the brain may be ordered to evaluate the pituitary gland and hypothalamus. Hypogonadism is primarily classified into two main types, primary and secondary, as we've discussed. Primary hypogonadism is also referred to as hypergonadotropic hypogonadism, indicating elevated gonadotropin levels. Secondary hypogonadism, also known as hypogonadotropic hypogonadism, signifying low or inappropriately normal gonadotropin levels. Within these broad categories, there are also specific conditions that cause each type. Examples include Klinefelter syndrome or testicular failure for primary hypogonadism, and Kallmann syndrome or pituitary tumors for secondary hypogonadism. The treatment of hypogonadism aims to restore hormone levels to normal and alleviate symptoms. The primary treatment for hypogonadism is hormone replacement therapy. In men, this usually involves testosterone replacement therapy, which can be administered through injections, topical gels, patches, or oral medications. In women, estrogen and progesterone replacement therapy is used, often in the form of oral pills, patches, or vaginal creams. If secondary hypogonadism is caused by a pituitary tumor, surgery, radiation therapy, or medication may be necessary to treat the tumor. For individuals experiencing infertility, fertility treatments such as clomiphene citrate or gonadotropin injections may be used to stimulate hormone production and ovulation or sperm production. While not all causes of hypogonadism are preventable, there are steps that can be taken to reduce the risk. Avoiding exposure to toxins and radiation, maintaining a healthy weight, and managing underlying medical conditions like diabetes can help. Prompt treatment of infections that can affect the gonads, such as mumps or chetus, is also important. Careful consideration of medications that can suppress hormone production, such as anabolic steroids, is crucial. Genetic counseling may be recommended for individuals with a family history of genetic conditions that can cause hypogonadism. The prognosis for individuals with hypogonadism is generally good with appropriate treatment. Hormone replacement therapy can effectively alleviate symptoms, improve quality of life, and reduce the risk of long-term complications like osteoporosis. Ongoing research is focused on developing new and improved hormone replacement therapies, including long-acting testosterone formulations and selective estrogen receptor modulators, SCRMs. Researchers are also investigating the role of genetics and environmental factors in the development of hypogonadism, aiming to identify new targets for prevention and treatment. Furthermore, there is increasing interest in the impact of hypogonadism on cognitive function and mental health, with studies exploring potential therapeutic interventions.